Next we'll be moving on to the instrument, and it will be taken up by Dr. Ushrin Bosch and Dr. Chiranjeev Dash.
So let's start with the retractors first. I'll do the ear instruments first, okay. So this is a Mollison self-retaining hemostatic retractor. So what are the other types of retractor that you know? Any one of you can answer. Janssen. Janssen will be a bit longer. They are longer and curved, but they also have 3 prongs. They also have 4 prongs. And the specialty about this is, it though it has got sharp ends. So the specialty of this, how is it self-retaining and also hemostatic? Though it has got sharp ends, but they are all curved outwards. And when they are curved outwards, the edges are actually, if you notice, they are very blunt. So they do not cause any tissue trauma, with minimal tissue trauma, and there is a ratchet lock. So this is called a ratchet lock, because of which it is self-retaining as well as hemostatic. So the other kind of retractor that is present is the Plester's mastoid retractor. Here you will have prongs on one side, it could be 2 prong or a 3 prong, and there will be a guarded blade on the other side. So this is typically used for our endoral incisions, and this also has a ratchet lock. All these retractors have a ratchet lock, yes? Plester and Perkins, no, this is Plester's. Perkins, I think both will be the guarded plate. I will find out, and after the...
Ushrin, I just suggest you better follow ma'am first. Whatever questions you might be having, because it will just break the flow. So we'll come up with the questions later on, okay? Continue, Ushrin.
So what happens here is, this is typically used for the endoral incision, where you can use this retractor to widen the incision that you have given, as well as in the other part where you have not given an incision, like the lower meatal wall. There you can use this guarded plate. Can anybody tell me what is this? And can anyone spell it for me? Right. So Paraveo's elevator, this is a periosteal elevator. So it separates, lifts and elevates tissue from the periosteum or over the bone. And it has got a ergonomically good handle where you can just place your finger, and it gives you a very good grip so that it does not slip away. This is around 12 mm wide, and the length of this instrument would be somewhere around 15 centimeters. So this is, we all know where it is used for elevating the periosteum during mastoid surgeries. Coming on to the Lempert's endoral speculum. So this is the anatomical position to hold the Lempert's. You grip the 2 handles. Again, ergonomically designed. There are serrations over here for a better grip, so that your hand does not slip over the stainless steel. You hold it in the anatomical position this way. You slide into the external auditory canal, and depending on how much you want to expose, you can control yourself. Okay, so this is again used for wax removal, cerumen management, foreign bodies removal, or also giving your 4-quadrant block during a tympanoplasty or before any of the local surgical procedures. These, I don't know if you are seeing, yeah. So we have 2 speculums over here. Anybody wants to take a guess which one is what? Yes. Rosen's. So what is the difference between this and a Tumacan speculum?
One is dark.
Okay. Acha. Yeah, sir. Pass on the mic when someone speaks, okay?
Ma'am, the difference being The color of the speculum, like one is dark and the other one is of stainless steel.
Not really. Actually, all of them are kind of chrome finished these days. So it is actually the shape of the speculum. If you notice here, Hartmann's is quite narrow at the. Hartmann's is. I thought you were using it for surgery tomorrow. So Hartmann's is very thin. It narrows down at the end of the thing. Okay. Tumakins can also be a slotted, but Tumakins is not this thin at the distal end. Okay. And this is?
The Rosen, this is Rosen.
This is Rosen, yes. They don't have the Tumakins unfortunately, but I think you all have seen a Tumakin speculum in your hospital, isn't it? Now coming on to the micro instrument. Perforator দিয়েছো? আরেকটা perforator দাও তো, এটা guarded আছে। Yeah. So this is a zig. It's a measuring zig. For measuring the length of the shaft of the piston that we use in the stepidotomy surgeries. Now we all know that there are multiple markings on this, 3, 3.25, 3.5, 3.75 up to 4.75. So we place the piston here and we give a sharp cut in order to take the desired incision, take the desired length of the shaft. Now in my hand I have a perforator, which is two kinds of perforator, one guarded and one plain without any guard. Can you zoom in here a little? Sorry. I don't know if it's visible. Not on my nails. একটু সরে যায় না এখানে এটা here. So we know that this is a perforator with a guard and this is a simple plain perforator. This is called the fish perforator. It is available in different diameters ranging from 0.3 up to 0.8. So depending on how you want to increase your stepidotomy fenestra, you can use various sizes. Now this also has an ergonomic design because you know that stapes is one of the smallest bones of the body and you cannot put in too much pressure. So it's very light, it does not slip away and you can just rotate it on the stapes to create the fenestra. Now what is the advantage of a guard over with the perforator? Whenever we are doing a fenestration, so the questions that you might be asked in the exam during this particular instrument exam is, why do we make a fenestra? Where do we make a fenestra? Can somebody answer? Mike please.
Fixed stapes foot plate in second stage surgery.
Sorry, once again?
Fixed stapes foot plate.
Yes.
We do it in a second stage surgery.
Okay, but where? Which is the position? Do you do it in the anterior part of the foot plate?
The posterior part.
Posterior part.
And why?
Because anterior is more thicker than the posterior is more thicker.
Because ma'am, the distance of
Yes.
the
I can't see you, but
ma'am.
Yeah.
Because ma'am, the distance of the saccule is 1.5 millimeter from the posterior end, and it is closer from the anterior end.
Right. So it's almost similar what he said. He said that the posterior part is thicker, but actually the distance of the saccule is much more in the posterior part than the anterior part. So you reach the saccule very fast in case you do it in the anterior part. That's why we always choose a posterior part, and the guard helps us exactly in that. Since there is a guard, even if you suddenly go inside or you have increased your diameter and your instrument slips in, it doesn't go suddenly into the saccule. It guards you over the fenestra. Okay. Along with this, I will also show you the house's measuring gauge. So, this has 4 limbs. The first one is actually the one which you will keep at the footplate of the staypiece, and the other 3 markings are the markings from the inferior border of the incus, body of the incus. That is how we do a stapedidotomy measurement, isn't it? So, we just enter into the small space where you have exposed your staypiece footplate, and you place the instrument on the staypiece footplate and measure this from the inferior border of the body of the incus. Now, the 3 markings signify 3.75, 4 and 4.25, and you are adding 0.5 each time with the measurement. Why is that? Why is that? Suppose I have a measurement up to the second marking. So, which length of piston shaft shall I put? Hmm? 4 mm. Second marking is 4.5. Actually it is 4, but we add 0.5 every time. Why? Because the footplate thickness, because you are taking this measurement before perforation, isn't it? But you will place the shaft of the piston after perforation. That means the part of the footplate which you have already finished it, that thickness has to be accounted for. So, it is ranging from 0.37 to 5.2 mm. That is why we take an average, we take around 5 millimeter. It is easier to remember. So, the markings are at 3.75, 4 and 4.25. So, if you have it in the first marking, the lowest most marking, then it is 3.75 plus 5, that means plus 0.5. So, that is 4.25. If it is at the second marking, you are using a 4.5 piston. If it is at third marking, then 4.75. Clear about this? This is not much like, this looks more like a ballpoint probe, but actually what I want to teach you here is the cell seeker. Now, what is the use of a cell seeker? We try to, traditionally it is used also to seek for the additus, though we all know that we do not drill a hole into the mastodantrum. Our philosophy towards mastodectomy has changed over the years. So, we do, but traditionally this was also used to find out the additus. Once the antrum is found, they used to see additus kotha hai, how much more to drill. So, that is one of the, so as the name suggests, this also looks for how many cells are left, how much bone you can drill around, especially near the dural plate. Suppose you are widely open, you have got your antrum, you have got your additus, but you want to know whether I can see, like the cases discussed before, where there is huge homogeneous opacity in the CT scan. You want to widely open, and whenever there is a cholesteatoma, you always want to follow the disease and not just scrape the squamous epithelium from there. You want to see where the bone ends, and from there you want to take it, isn't it? So, sometimes there is a low lying dura, and dura is usually low lying in the lateral most part. So, when you are in the medial region, you might want to see how much more I can drill safely. So, this is a very useful instrument. The next instrument is the Beal's elevator. The Beal's elevator, that is Beale', or a lot of people synonymously call this as a Rugen's elevator. Both of them are named after the ENT surgeons. So, this instrument is a useful instrument in order to reposit it is mostly used for repositing soft tissues in the ear, and since it is a micro ear instrument, it can be easily navigated through into the small spaces of the middle ear. So, repositing back the posterior tympanomeatal flap or elevating the flap sometimes can be done with this instrument. The next instrument is, have you given me a curved pic from the microset? Needle pic, angle pic. So, this is a curved needle, it is gently curved. Now, a lot of people use curved needle and a pick synonymously, but it is not so. A curved needle is very gentle. It's used to remove tissue, to move away tissue from the incus head, the body of the incus, sorry, to remove the epithelium from the malleus. Okay. This can be sharp or blunt. Depending on the sharpness, you can use it for whatever purpose you want to use in the middle ear. But I want to show you the, yes, I want to show you the pick. Now these angle picks are available in various sizes. So this is a 0.5 mm pick and also in various angles. So this is a 45-degree pick. This one is a 45-degree pick. It's 0.5 mm. Depending on your make of the company, it could be conical, it could be just a single line. So, but it is usually sharp. Now, where and all would you like to use this? This can be used to separate the suprastructure of stapes during stapedotomy in the anterior crura, or just cracking the posterior crura just before you make that move to remove the suprastructure from the stapes foot plate. Also to remove the round window membrane during cochlear implantation surgeries at the end just before inserting the electrodes. And yes, a few places where you want to do very fine work near the handle of the malleus or with a intact ossicular chain where you don't want too much of movements in the ossicular chain system, you can use this picks. Now these are available in 90 mm also, and it ranges from 0.5 to up to 3 mm it's available. So you get quite longer picks as well. And yeah, and quickly, this is a fenestrated circular knife. The advantage of a fenestrated circular knife too, they don't have it here, a normal circular knife which does not have fenestra, is only that when you are elevating the posterior tympanomeatal flap, you are supposed to keep the suction over this instrument and not directly into the flap, so that your flap does not tear. Okay, whenever you are elevating the posterior tympanomeatal flap or the anterior tympanomeatal flap as such. This is a malleus snipper used for nibbling the malleus, the head of the malleus mostly. Okay. Also sometimes when you will see that the malleus is sort of retracted and touching onto the promontory. So the inferior part near the umbo, sometimes we need to nibble that off as well. So this is a simple bone punch kind of thing, but also like a micro ear. The other things which you all know is a micro cup forceps for removing soft tissue from the middle ear. We have crocodile for again removing soft tissue or a few strands of fibrous epithelium from the middle ear spaces or the disease itself, and micro scissors. এটা হয়ে গেছে এগুলো দিতে এটা একটু ওঠাতে হবে, এইগুলো দিতে হবে না, it's not required. And this is another micro ear instrument which you must know, that is the, thanks, this is a house micro ear curette. So this is again depending on the make, it could be a bit curved, but they are basically bone curettes which can be used during removing the posterior superior bony removal, bony overhang removal during stapedotomy surgeries or any other surgeries for that matter, or during canaloplasty also. A lot of times we use this when you don't have a drill at hand or they are just making the drill ready, you can just go on curetting with this if the bone is soft. Now I will just show you this burr. Can someone answer me what is the specialty of these kind of cutting burrs? Do you know what is a fast cutting and a slow cutting burr? Anyone?
Distance between the serrations will determine whether it is a fast cutting or a slow cutting burr.
Yes. So this is a relatively slow cutting burr. It is not the slowest cutting burr, but it is a relatively slow cutting burr than a fast cutting burr. Okay. So now the amount of serrations, the lesser the serrations, the faster cutting burr it is. So depending on that, you are supposed to decide where you want to take which burr. Like when you have already thinned out the dural plate, you would never want a fast cutting burr. You would always want a slow cutting burr or probably an older burr which you have used 3 to 4 surgeries old, so that you can smoothly drill out the dural plate. And this is a diamond burr. Now diamond burrs can be coarse or fine. Fine diamond burrs, what is the function of fine diamond burrs? Why do we need them? It is usually used for the polishing of the mastoid cavity during saucerization, the final touch that you want to give to the mastoid cavity. The coarse ones are used mainly for hemostasis, also at places where you want to use a diamond and do not want to suddenly injure the structures beneath, like the sigmoid sinus, the dural plate, all of these areas, also over the facial nerve. But with this, whenever you are using it over the facial canal or the fallopian canal or the facial ridge in the mastoid, you are supposed to irrigate copiously, because these are notorious and they are known for producing too much heat, too much. If you ever touch it yourself during the procedure, you will know that this releases a lot of heat, so which can go into our facial nerve and injure the facial nerve, maybe temporarily, but still. Now I will come to the nasal instruments. Now this is a Killian's self-retaining nasal speculum. What is the difference between this and this? It is available in various sizes up to this is around 1.5 inches or 10 centimeters around, and this is a smaller one. So depending on what use you want to do it as, this, suppose you are doing a vestibular lesion, you can just use this one, retract your nasal nares and screw it up so that it is stuck in this position and you can work. So both your hands are free and you can work in this. Okay. And this is a long bladed Killian speculum. We use it in the septal surgeries, post septal surgery, in order to look for the nasal airway, or if you are doing a septal surgery with a headlight, you might want to remove bony chips from the septal flaps. So it can be used very precisely for that. This is a Lux instrument. Now Lux instrument has a fenestrated cup for sure, but it is very sharp. This is what makes it different from a Blakesley. This is a Blakesley instrument. If you look into two things, there are two differences. One, Blakesley has a hinge joint, it is just this much, whereas Lux has a box joint. And Lux, unlike what we know to remove polyps and tissues, Lux is ideally used for removing cartilage, bone punching inside the nose for septal surgeries. Okay, because this has a sharp edge, it can very precisely cut. Suppose when you are trying to, we leave that 5 mm strut anteriorly and superiorly in the septum, right, when we want to do a proper SMR, and you still feel that no, the upper part is a bit deviated, you can take a Lux and try breaking the cartilage. It does it wonderfully. Okay. Now Blakesley, what it does, there is a fenestrated cup once again, but the cup is quite smooth. So they hold the tissue with minimal trauma. They are grasping forceps, but they make very less trauma, and you can also remove bone chips from the nasal cavity with this. So it can be basically upturned, right turned, left turned, or different angles. Okay. Now this is a Wiley Blakesley true cut forceps. What is the role of this? It grasps the tissue in between and cuts it sharply. So you can use it for doing a biopsy or doing an uncinectomy. During an uncinectomy, you want to take out a part of the bone along with the mucosa, you can always do that in completion of uncinectomy. These are Fess scissors, endonasal Fess scissors. Yeah, and this is a backbiter's forceps. The most common use of backbiter forceps, Again? Mike, it's kept in front of you, no?
Swinging door method of Wormel's uncinectomy.
Right. And what were you saying? Uncinectomy. Okay. So the main use of this is doing an uncinectomy. It is also available in a rotating ridge sometimes with the make of the company. You can enter this way and engage your forceps into the middle meatal antrostomy region and take a bite or make a Parsons window. This is a horizontally opening giraffe forceps. It is also available this way, like vertically opening. So these are the two things. This is used for frontal sinus surgery because of the make. Frontal sinus is way up and anterior actually in the nose, and that's why all the frontal sinus instruments are like this. Even the kerosene punch for frontal sinus will be in this make only. I'll also show you another mushroom punch to dekho it. So this is a Stamberger's mushroom punch forceps. This is used for, actually this is used for the frontal sinus and also be used for the sphenoid sinus. So basically first it engages the tissue here and it snaps. Okay, that's the use. It's known as the Stamberger's mushroom punch forceps. Okay, you're all familiar with these things. These are the olive pointed maxillary sinus suction forceps. If there would be no olive point with an acute 90-degree bend like this, it would be the frontal sinus forceps. Okay, and for the sphenoid sinus, you have an S-shaped forceps. So if any examiner shows you an S-shaped forceps, say that that is for the sphenoid sinus. This is a suction Freer's elevator. The only thing that you need to, all know how this works, but sometimes there is also a control over here. If there is no control, be careful to reverse it in places where you should not directly go and hit into the artery or a tissue with the suction, like in sphenopalatine artery ligation, in ESPAL, endoscopic sphenopalatine artery ligation. When you are trying to remove the mucosa from over the crista ethmodalis to locate the sphenopalatine artery, make sure that it is on the other side so that the tissue is also removed. You can still have a view with a good suction and also not damage inadvertently the sphenopalatine artery. Okay. We don't have a kerosene here unfortunately, but this is a sphenoid bone punch. Kerosene is usually longer, and you all know the use of kerosene. It just punches the bone, and you can do it for an anterior sphenoidotomy or in a frontal sinus. The last instrument that I would like to say is, this is ash and this is Walsham. Now ash is kind of bent. Why is it bent? Because you have to just imagine, you have to just place it on either side of the septum and crush the septum, lift it and realign it. So this is for the septum and this is for the malandine nasal bones on both sides. Usually it comes with a guard also. You can put a rubber padding here so that the inner mucosa is not injured. Now I'll hand it over to Dr. Chiroji.
Next is Dr. Chiranjeev Das, and he'll be taking up the tonsil instruments and the scopes.
Good afternoon, everyone. I will show one by one instrument. The questions you will be asked in the exam. First is, what is the name of the instrument? So, can you see? Anybody?
Lux tongue depressing
Lux
forceps.
tongue depressor. Then next question is, what are the uses? Tell me.
So used in non-dominant hand to depress the tongue for examination of the oropharynx, other parts of the oral cavity, and also used sometimes while doing a posterior rhinoscopic examination.
Okay. You have said the diagnostic uses. There are some therapeutic uses also. Okay. Tell me. Okay. Biopsy from where? Next. Other than that. Yes, foreign body removal. Then there's you have missed some diagnostic test, that is
course vascular test.
Okay. So the next instrument is sorry Jadavpur. Boyle Davis mouth gag. Which part is Boyle and which part is Davis? D is for this and Boyle is for blade. Okay. Then the next question you will be asked in the exam, how to hold the instrument. Okay. And you will hold the instrument like this. Okay. So use in tonsillectomy, adenoidectomy. Then what is the name of the instrument? This is Doughty tongue blade. What are the difference between Boyle tongue blade and Doughty tongue blade? Slot for endotracheal tube. Okay. The next instrument is this. Why you are saying that this is Dennis Brownie tonsil holding forceps, not Lux biopsy forceps? Because the joint is box joint. In Lux biopsy forceps, this is screw joint, and the tip, the blades are blunt, smooth, and in Lux biopsy forceps, the blades are sharp, and in here the superior upper blade is shorter than the lower blade. Okay. Next, tonsillar knife with dissector. This part is knife, this part is dissector. For dissecting which part of the tonsil?
Loose alveolar fat.
For dissecting the upper pole of the tonsil after just giving the incision. This is also tonsillar dissector. Okay. This is the name is Gyne-Evans tonsillar dissector. Gyne-Evans, G-W-Y-N-N-E. One end is blunt, one end is serrated. Which part is used in which step of the tonsillectomy? First, blunt end is used for dissecting from the upper pole and pillars, and for dissecting from the beds, the serrated end is used. Okay. Then Reeser was dissecting forceps. Okay. Use to pass the cotton swab into tonsillar fossa during dissection of tonsil. Most of the instruments are held in pen holding fashion. So what is the name of this instrument? Molition, anterior pillar retractor and dissector. Okay. name Burkitt artery, tonsil artery forceps, use to catch hold the bleeding vessel after removing the tonsil in tonsillar bed. Nigas tonsillar artery replacement forceps, use to replace the previous one, that is Burkitt tonsil artery forceps after and for ligation of the lower pole of the tonsil. And what other instrument is required for ligation of the lower pole? Nigas, ligature slipper and knot tire. Okay. For cutting the tonsil from lower pole, this scissor is used. Okay. St. Clair Thompson adenoid curate with cage. Then how you will hold the instrument? In dagger holding fashion, like this, not like this, like this. Okay. And which part is cage? How to dismantle the instrument and how to reintroduce this. Okay. First you, then so which part is cage? In my left hand or right hand? Left hand. After adenoidectomy, you will take out the cage and clean the cage from adenoid tissue and reinsert into the adenoid curate and again curate the adenoid. Okay. So why the cage is there? To prevent slippage of the adenoid tissue in the nasopharynx. Oh. The long instruments, Graffin's bipod and Magaron's plate. Okay. Younker's metallic suction tube. Okay. What is the speciality of the suction tube? The tip. The tip is, there is a separate knob in the tip which is blunt to prevent injury in the tonsillar fossa. There are multiple holes, not only in the tip but also on the sides. If there is blockage of the hole in the tip, the side ports will act for suctioning of the during operation. What other instrument is there in ENT in the name of Younker's? Younker's nasopharyngoscope for examination of nasopharynx. Okay. Next. Anybody? Tell the name of the instrument. Klein-Sasser, suspension laryngoscope for microlaryngeal surgery. There are one another variety of scope, that is direct laryngoscope. What is the difference between direct laryngoscope and suspension laryngoscope? This part which I am holding, this handle. In direct laryngoscope there is vertical handle, also a horizontal part of the handle. In suspension laryngoscope the horizontal part is missing. There is a hook for suspending it from recurved chest piece with jack. So
dilate the tracheal opening and
opening.
the tracheal stoma.
Yes. So after making the tracheostoma, to dilate the tracheostoma and for during change of tracheostomy tube, Okay. double hook blunt retractor and single hook blunt retractor. There is also single hook sharp retractor. What are the uses?
To retract the isthmus during tracheostomy.
With this
with
blunt
this
hook. And what is the use of sharp one? Sharp variety? To hook the cricoid cartilage and hook it upwards. Now the two long scope. Okay. The left one is esophagoscope and right one is bronchoscope. Why? Anyone with take the microphone?
The bronchoscope have the multiple openings for the ventilation
At the distal part.
at the distal part.
Yes.
And the esophagus scope have the only the distal part one opening, and it is the longer one. And
The
bronchoscope
lumen-
have the multiple opening for the suction.
Okay.
And
Other parts? Other difference?
Sir, the
Cross
cross
section?
section of the
Huh.
so the cross section of the esophagoscope will be oval and
Oval.
the bronchoscope would be circular.
Circular. Yes. And
And port
ports. Yes. In the head part is in the esophagoscope. They are only for instrument port and light port.
Lights.
Okay. In the bronchoscope, there is light port, instrument port, suction port and anesthetic port. 4 ports. Okay. In the instrument port, there is a adapter. What is the name of the adapter? Flew-Vog adapter. Okay. Why this type of arrangement is there? Some is open. There is some opening here, blood, this is blocked with the glass. So the opening is for instrumentation. Okay. And when the patient instrument is out, patient is ventilated, then this port, this is kept over the port to block the air leak. Okay. Then how will you introduce the scopes? Esophagoscope, hold in pen holding fashion in the dominant hand. With the non-dominant hand, you retract the lips and teeth, open the mouth and go through the oral cavity, okay, through the pyriform fossa, one side, then see the arytenoids, go below that in the cricopharynx, go to the cricopharynx, wait at the cricopharyngeal sphincter to open the sphincter. Okay. You will wait until the sphincter is open and then gently introduce the esophagoscope. The bevel end is always upwards. Okay. So, what are the curvatures of esophagus? Natural curvature, sideways. You have to know during introduction of the esophagoscope. Anyone? There are two left-sided curvature. One is in the neck, one in the thorax, and there are anterior posterior curvature. Okay, according to the curvature of the spine. So accordingly, you have to adjust the patient's position. Sometimes neck is extended, sometimes neck is flexed. Okay, now sometimes you will have to give some hand below the chest. Okay, to counteract the curvature of the esophagus during introduction of the esophagoscope. Okay. And how will you introduce the bronchoscope? There is also a bevel end here at the tip. You will first, what other instrument is needed for bronchoscopy? Yes, Macintosh laryngoscope, that is used by anesthetist. First you see the epiglottis with the help of the Macintosh laryngoscope. Then you introduce in the pen holding fashion with the bevel end up below the epiglottis, go below the epiglottis and just you see the vocal cord, then rotate 90 degree. The bevel end should be on the side. Pass the vocal cords, introduce the bronchoscope gently, you will see carina, that is bifurcation of the trachea, and then you go one by one on the both side. Okay. So, what are the how will you maintain the patient during bronchoscopy, anesthesia? Anybody take the microphone? Anesthesia during bronchoscopy. Take the microphone.
Sir, a good amount of pre-oxygenation should be ensured.
Yes.
Followed by that, a multidisciplinary team anesthetist should be on foot and ready, and preferably experienced anesthetist with adequate team. And throughout the procedure, saturation should be maintained. Whenever it's going down, we need to stop instrumentation and give them time to reventilate.
Okay. So, the first is pre-oxygenation, then intermittent ventilation. But the problem is there, it is open circuit. When other surgeries are performed, it is closed circuit, but during bronchoscopy it is open circuit, because you are working in the same channel for anesthesia and for also the bronchoscopy. So, it is open circuit. You can close the tip head of the bronchoscope with the Fluevog adapter, but you cannot close the holes on the distal end. Okay. So, you have to be cautious about the saturation of the patient. Okay. You may need to sometimes remove the whole bronchoscope and do proper ventilation of the patient. Okay. Then other these are instruments for laryngeal forceps. This is cup forceps. This is laryngeal scissor. These two are esophageal forceps, not bronchial. This is esophageal forceps. This is serrated crocodile forceps for removal of foreign body, and this is for suction, esophageal suction tube. Okay, that's it. Thank you.
Is there any question related with the instrument part to any of our speaker?
So the one that I showed you is a plesters because it has got unequal blades. So the guarded blade will be longer than the prong blade in plesters. So the one that we have here is the plesters. You can have a look later while you're going for lunch. And in Perkins, the two blades will be of the same size. Yes, one can be guarded, and usually in Perkins you have 3 prong. You don't have a 2 prong. Okay.
Another question, ma'am. I have seen variety of surgeons using the Walsham differently. Some use the smaller side outside, and some use the smaller side inside. So, what's the correct?
And keep this on the bony surface and manipulate as you want. Okay. Eta jodi bhetore rakho, if you keep this inside, it will cause a lot of mucosal trauma. First. Second is, the bone is on the lateral surface of the dorsum, isn't it? So, this touter thing should be on the dorsum. You remember that.
As she said, the chances of injury will be minimal. So, whatever you have seen or learned, try and make a modification on that, because the broader part has to be outside. Okay. I'll just put this session to close if there is no any other questions left in the instrument part.